pulmonary side is you're providing artificial respiration, so we're breathing for the patient as well. So a layperson CPR is performed differently than CPR for healthcare providers. Why would that be?
Because they don't have all the equipment that we do.
Exactly, we're set up for it, right? We're ready for it. A layperson may be just out at Chipotle eating lunch and someone drops unresponsive, pulseless, and they start doing chest compressions. But we have, and they're waiting for us. We have the stuff for it. AEDs, automated external defibrillation. Available in many public facilities and fire apparatus that do not carry paramedics. And also, you know, our heart monitors, they have an AED on them because we do have paramedics. Use as soon as necessary if available. Research shows that early defibrillation increases the chance of getting resuscitation by a lot. I don't know the exact percentage, I have to look that up, but it makes a big difference. That's why we're emphasizing getting the AED put on really early. So once we put it on, we're gonna follow the AED's prompts and instructions. We open it up, turn it on, and it will actually begin to tell you what to do. It'll tell you shock advised or not, and to clear the air, clear the patients, because if we get this on and we're getting ready to shock this patient, we don't want any of us touching the patient, because once that shock goes through, it's going to the patient, but it'll go to us as well. If the AED is unsuccessful, doesn't provide a heartbeat, or reset that heart to where it starts beating, continue to do manual CPR. Chest compressions. It's the main component of CPR. Forces the heart manually to circulate blood through the body. Patient survivability during cardiac arrest improves with early administration of compressions, performed in different ways depending on patient age. Use AED if it becomes available. So just real quick, and this is on your guys' skill sheets. But when we do our compressions, we want to use the weight of our body and not just our arms. If we're doing this, you're gonna get really tired. But if we're above and we interlock our fingers like this, lock our arms out, get up, and we want to push hard enough that we're going to get like 2 inches of depth at least, right? And how many beats per minute is really important too. We want to be at least 100 beats a minute. And so what I want to do when I'm doing that, I kind of sing a song in my head. And it's the song Staying Alive by the Bee Gees. So I'm just like, staying alive, staying alive. And as long as we're going fast enough, we're gonna be perfusing the blood that's in there that's getting oxygenated. We're gonna be perfusing those cells enough that we have a potential of bringing that person back. Any questions with that?
I like Pump Up the Jam.
Pump Up the Jam, it's not a good one. Any song that's like 100, 120 beats a minute, just go ahead and sing with it. All right.
You want to take a break?
Yeah, let's take a break. We'll be back in here, it is 1:43. We'll come back in here at 1:53. Sound good?
like 2?
Yeah. I mean, you've been sitting here a long time.
Stinging in there? I never heard it pump up.
Oh, shit.
Pump up the jam, pump it up, pump it up.
You're the man, Jason.
Oh yeah. I had to redo all mine. I had to go to class and everything.
We literally just took the written test.
Did you?
And came straight here. It's due in 2 days.
Oh shit. Did you guys pass or written?
We don't know.
Not good for nothing.
It could be.
We told you this morning.
Just like you won't know for like
What's today, the last day?
2
days.
4th.
Oh, okay.
2 days.
There's no way. I don't even care, man. It's just like whatever. Too much crap going on. Sit there and try to stuff a bunch more stuff.
Yeah.
We forgot about it.
Yeah, it kind of flew by.
Well, we forgot about it, so we use course completion.
Oh yeah,
Also,
that
last
changed.
minute, hey, you know, life happens, we're busy.
Yeah.
Not that you officers do. Yeah, you need instructor. Oh wait, no, officer gave you like 2 or 3 days to do it, didn't it? So I might even get an officer.
Oh yeah, you got a whole bunch for that.
I just need instructor again. I don't even want it.
All right, we're all back from break.
All right. Well, I sure appreciate you guys.
Oh yeah.
So we're gonna finish the last half of this class, as far as the curriculum goes, and then what we're gonna do is we're gonna go through these skills again, practice them together for a round or so, and then we'll take our practical test, and then we'll do a written test and be done. So anyway, picking up where we were on CPR. So chest compressions, the lay person doing CPR out in the world, obviously not gonna have the equipment we have. They're pretty much gonna focus more on compressions than on ventilation, just continuous CPR. But for us, we're gonna do full CPR, which is chest compressions and rescue breathing. So, let's say you come up on somebody unresponsive, right? We're gonna determine if they're conscious, or come up on somebody that's laying down or looks not right, looks sleeping or something's not right. We're gonna determine their consciousness. We're gonna determine if the patient has a pulse, and then we're gonna start compressions if no pulse is found in that 10 seconds. And then we're gonna notify the communication center of the condition and resources needed. So what that might look like is, hey sir, are you awake? Can you hear me? Hello? Hello? Nothing? I'm gonna check for a pulse. I got nothing. I'm gonna immediately get into doing my compressions that we just talked about. And you know, your partner's gonna get the AED set up, and we're gonna go through all that. And then, but for today, as far as the skills, what that's gonna look like is you're gonna do that, and you're gonna get into your one rescuer CPR, which is 30 compressions, 2 breaths. 30 compressions, 2 breaths. We're gonna do that for 2 minutes. At that time, your partner's gonna arrive with the AED. We're gonna get that set up, which we'll go over in the skill portion, and then see if it's a shot forward and go from there. That's what you're being tested on today. Chest compressions, I just kind of talked about this right before the break, gave some examples. We won't spend too much time on it. But the target we're looking for is directly in line with the nipples, right there. Keep arms straight, using our body, not our arms. We're gonna pump right there. Chest compressions for adults, with victim on his or her back, tilt the victim's head back to open his or her airway. And then just like I said, straighten your arms, don't bend them. Keep your weight over that, so you're using your weight. And we're gonna go press down on the chest, to depress the sternum, and you're gonna feel it depress, 2 to 2.5 inches, but no farther. While it may be difficult to judge the depth of compression, compressing to a greater depth may potentially harm the victim. They're already dead, so you're only gonna be helping them. Lift up to release the compression. The chest should recoil completely to allow the heart to fill itself. Keep your elbows locked at all times and do not remove hands from the compression location. Breathe twice into the victim's mouth while holding the victim's nose closed every 30 compressions. So like I said, 30 and 2.
Is that mouth to mouth?
What we're gonna use is actually a bag valve mask. And what that looks like, we're gonna grab this device. We're going to turn this pointed side towards the nose. Do what's called a C-clamp, where we hold a good seal on it, or and give 2 good breaths. And we should see adequate chest rise if we're doing that correctly. Now, what sometimes will happen is people don't have a good seal, and they're not actually really pushing the air into the lungs, but we wanna make sure we got a good seal. And then we're gonna go, after doing 2, we're gonna go right back to our compression. About 100 beats a minute. 30 and 2, 30 and 2.
Question.
Yeah.
You said the target's center mass between the 2 nipples. But those landmarks are lower.
Yeah, that's a great question, actually. So we're gonna just go right above kind of that xiphoid process area, right there. Go just right above that and put the heel of your hand right into it. Kind of make that, I don't know what you call that grip right there.
CPR grip.
The CPR grip, just kind of interlock your fingers. Keep your arms straight, you're good to go. All right, and then like I talked about before the break, we're gonna do it 100, 120 beats per minute. Really good way to stay on pace with that is songs that are 100 to 120 beats per minute, just kind of sing them in your head. And go from there. All right, while performing chest compressions, it is often common to hear or feel a patient's ribs break due to the pressure. While this sensation is not pleasant, it is a sign of quality compressions and should not discourage you from continuing. It is a weird feeling, doesn't feel good, but if you don't do that, you're not doing compressions deep enough and you're not potentially saving their lives, so. All right, chest compressions for children, they're a little bit different. We're not actually being tested on, we're being tested on one rescuer CPR on an adult, so I won't spend a whole lot of time here. Smaller child, we're gonna use one hand. Larger children, like adolescents, you know, we're gonna use 2 hands still. I would say if they're 7 and under, we'll definitely use it. Maybe 9 and under, definitely using one hand. It just depends on the size of the child. Adult techniques can be used on larger children. It's still 30 and 2. It's the same. Once we get into infants, that's a little bit different. Most of the time, if an infant is going to need CPR, it's because of an airway problem. It's most of the time not because of a heart problem. So what they want you to do is when you determine the patient's status, you see that, okay, this child needs CPR, we want to check their airway. So we want to see if there's any foreign obstruction in it, if we can suction it out or have, you know, one of our paramedics grab it out. Same thing, we're actually gonna check for a brachial pulse, so instead of a carotid pulse. We're gonna do that for about 10 seconds. And essentially follow the same format, so. Now this is where it's a little bit different. We're not gonna use, you know, 2 arms or even 1 arm, but 2 fingers because of how tiny their chests are. And you're only gonna go about 1.5 inches deep. Still same rate, 100, 120. But if you are doing 1 person CPR with an infant, it's actually 15 and 2. So instead of 30 and 2.
And you don't wanna break the ribs.
Makes sense. What is the purpose of performing chest compressions during CPR? Jason, can you tell me?
Getting blood flow, oxygenated blood flow into the body.
Manually pumping the heart because it's not pumping itself. Exactly. How is the process of performing chest compressions for infants and young children different than for adults? We just kind of talked about that.
That's a little more fragile.
Yeah.
One hand, two fingers.
One hand, two hand, or two fingers.
Two thumbs.
Yeah. Discontinuing CPR. We do this a lot. Periodically reassess patient and discontinue CPR if patient moves or regains consciousness. That's a good sign, right? We got the heart back to pumping, we kind of reset the heart. That means they don't need CPR anymore. Patient has a pulse, patient breathes. You hand over care to a rescuer with higher level training, or the physician instructs you to stop. I'm also going to add our protocol. So what do our protocols say? If we've been doing CPR for 25 minutes in the field, then you know, the medic on the scene will terminate CPR and call it in the field. Cardiac events are emotional, especially if patients, family, or friends are present. You may be subject to anger when deciding not to begin CPR or when discontinuing CPR. Speak calmly with the family and friends of the deceased and keep their feelings in mind when discussing the patient with other responders. You know, we don't want to be, obviously we run calls like this a decent amount, so it might be less traumatic for us than for obviously a family member. You know, we want to be sensitive and not talking about the Royals game that night or cracking a joke with another responder. We want to be sensitive and tactful. At what point should you discontinue CPR? 25 minutes, that's our protocol. Objective 7, describe methods of controlling bleeding. So now we're going to get into bleeding control. Obviously, blood transports oxygen and nutrients to cells to keep them alive. Maintaining blood flow and volume is extremely important, which is why we have to be ready to stop bleeding so patients don't bleed out. So there's different kinds of bleeding. As far as external bleeding, we have laceration, it's a cut, puncture, you know, someone gets stabbed, puncture, and then abrasion. And we see real bad abrasions and oftentimes like motorcycle accidents or something like that. We get road rash real bad. Arteries, so there's arterial bleeding, is when an artery is obviously bleeding. Arteries transport blood away from the heart, and then blood in arteries is bright red and under pressure. So if you see pressurized bleeding, you know, like the spurting, it's probably an arterial bleed, and that's what will make patients bleed out the fastest. So we really got to get that under control. Arterial bleeding occurs when the artery wall ruptures. Often difficult to control from just pressure. I'll have to use a tourniquet on that one. It is a true medical emergency. Bright red, spurting or pulsing blood. Bleeding that's from a vein is normally going to be a darker red because it's not as oxygenated as blood in the arteries is, and it's going to be more of an oozing than a spurting like that. Veins move blood back to the heart after it delivers oxygen to cells, which is why it's darker. It's more of a slower, steady bleed. Areas between arteries and veins where oxygen and nutrients and blood are delivered, it's the capillaries. Carbon dioxide and waste are removed by the blood, and then blood moves relatively slowly. Capillary bleed, you know, we're probably, I hate to say we do get caught on them sometimes, but for the most part, you're not going to get toned to a capillary bleed. Really superficial, not much blood, and not much severity. The only time which is not a emergency, but they could get secondary infections and stuff like that, it's likely to well, so we do need to keep that in mind. What are the 3 types of external bleeding?
Function.
Arterial,
Yeah.
venous, or venous.
Venous and the capillary.
Venous.
Yeah. And then also, I mean, you're on the right track too. You got the
It's about punctures,
lacerations, punctures, and
abrasions.
abrasions. Provide an example of each of the following types of bleeding: arterial, venous, and capillary. I think we already kind of did that. All right, controlling external bleeding. Direct pressure, elevation, or combination of both. We have certain protocols and standards for the way we do it. Well, we're gonna, unless it's spurting an obvious arterial bleed, we're gonna start with direct pressure. Direct pressure is going to get that bleeding to stop. I mean, pretty much every time, unless there's some weird circumstance that we don't know about. We're gonna apply pressure with a gloved hand in a 4x4 or a 5x9. If blood soaks through, apply more dressing instead of removing the soil dressing. Just take more 4x4 or 5x9 and just stack it on top and keep holding it down. Continue until all blood ceases to soak through. Apply bandage to hold dressings in place. So our Herlex, we can tie Herlex around to hold it in place. Now severe bleeding, apply direct pressure with gloved hand immediately. Blood can be lost quickly, so no time should be wasted. Apply dressings and bandages after they are located and opened. Now, some of the superficial injuries, you know, if you elevate it above the heart, you might slow the bleeding down a little bit. But for us, what we're going to do, we're either going to use direct pressure, or if it's an obvious arterial bleed, we're going to take one of our tourniquets and wrap it around, right? Internal bleeding may occur when blood vessels rupture inside the body, not as obvious as external bleeding because you don't necessarily see it right away. But signs and symptoms of that are significant bruising or other indications of injury, especially involving the patient's torso. Bleeding from openings such as mouth, nose, or rectum, bloody stool or urine, painful, swollen, or rigid abdomen, blood's pooling there. You see some of this in like blunt force trauma, in car wrecks. Vomiting of substance resembling coffee grounds, that's bad. Cool, pale, clean skin, gonna start getting into shock management, that's what that looks like. Those are obvious signs and symptoms with mechanism of injury of potential shock. All right. Okay, explain shock management. On to objective 8. Is everybody doing all right?
Mm-hmm.
More comfortable still? All right, we got a few more objectives to get through, and then we're going to do our skills and tasks and be done. Explain shock management. Shock is when the body is unable to regulate itself and maintain normal function. The body is unable to supply enough blood to vital organs to keep them functioning. So, if we don't have enough volume, if we're bleeding, whether it's externally or internally, we're losing the volume of our blood to be pumped through our blood vessels to oxygenate our organs and organ systems. So this is a very serious issue. So there's 3 different types of shock: hypovolemic, cardiogenic, and neurogenic. Causes of shock. Number 1 is going to be trauma. Obviously, if you have some type of traumatic injury where you're beginning to bleed, your body is going to run out of the volume of red blood cells to carry oxygen to your organs. Anaphylactic, it's interesting. You can have actual shock from having an allergic reaction. And then septic infection. So those aren't as much, or they're not trauma related, but we'll get into the systems of what causes that. Hypovolemic, just talked about that.